Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Ahmed and Dr. Mimon, for introducing my lecture. I would like to thank the organizing committee for inviting me to present this big topic, is upper GI bleeding. So we'll talk brief about management. Here's the outline. First, we will talk about pre-endoscopic management. Then we will talk about during endoscopic management, and at the end we will speak about post-endoscopic management. So initial is hemodynamically resuscitation is very important. So it has to be immediate assessment to restore the stability, used two large peripheral IV axis, and if you need a central line, it has to be done for the patient. Initial volume replacement with a crystalloid, it has been shown is better even than a colloid. For the airway management, if you think patient cannot maintain the airway, so go and intubate it. It's only in the indicated because the study showed if patient does not intubate it, the outcome it gets worse compared to those who's not intubated. So let's be careful just for those patients who cannot maintain the airway. Regarding the blood transfusion, there's a few considerations you should keep it in your mind. Is there ongoing blood loss, patient comorbidity, ischemic heart disease, peripheral vascular disease, congestive heart failure, chronic liver disease, current hemodynamic status, evidence of tissue hypoxia, then you should keep in your mind the adverse event of blood transfusion like a reaction, congestive heart failure, nosocomial infection. And a very important thing, please do not depend on initial hemoglobin when patient presented to the ER. It should be repeated after resuscitation to decide about the blood transfusion. Here is a well-known study. It has been published in New England Journal 2013 by Villanova, showing restrictive blood transfusion strategy is superior, and there's a two-group is restrictive strategy. They only transfused patient when hemoglobin is less than 7, and liberal transfusion, they transfused all patients if hemoglobin is less than 9. But keep in your mind, they exclude the patient with ischemic heart disease. So they found those patients who had a restrictive strategy, the survival were better compared to those patients with liberal strategy with a significant p-value. So here it's showing it's favoring a restrictive strategy compared to the liberal strategy. We should keep again in blood transfusion, it has to be less than 7 grams per deciliter. Higher threshold hemoglobin concentration, it has to be considered as less than 9 for patients with cardiovascular disease. So risk stratification at the patient presentation is very important. Most of us, we are not doing it, but it has to be done. This is a Glasgow score. It's including systolic blood pressure, blood urea, nitrogen, its hemoglobin concentration, and other risk factors like pulse, melena, syncope, hepatic disease, and the cardiac as a failure. These it can be used in non-hospitalized patient, and patient is ambulatory. It has to be kept in your mind. You cannot use it in patient or ICU patient. So a score of 2 or less, patient can be managed as outpatient. He can be discharged from ER scope next day. There is other score. It's called a ROCAL score. It's containing the age of patient, hemodynamically of the patient, is he shock or not, comorbidity. It's required endoscopy, so you cannot be used at the ER because it has to be endoscopy done for this patient and decide about the diagnosis and if there is evidence of active bleeding or not. So it cannot be used at the ER level. It has to be used for ICU patient or after endoscopy. So this is very simple score. It has to be used. AIMS 65 is including albumin, which is less than 30 or 3. INR is more than 1.5. Mental states altered. Systolic blood pressure is not less than 90, and age is more than 65. So it's higher. It's high accurate for predicting inpatient mortality among patients with upper GI bleeding. It's zero risk. The mortality risk is less than 0.3. 5 risk is considered as very high. The mortality is more than 25%. So once the score is increased, so there is a risk of increasing the hospital stay. So now we will talk about BBI before endoscopy. So why we are giving a BBI before endoscopy? So here is a Cochrane meta-analysis, including a 6 randomized control trial comparing pre-endoscopic BBI with placebo or H2 receptor blocker. The benefit is on downstaging of the ulcer and needed for endoscopic therapy. There is no benefit on the mortality, rebleeding, and the surgery. So these should keep in your mind. In acute upper GI bleeding, PBI prior to the endoscopy, it has to be considered, but should not delay or replace urgent endoscopy. There's another issue in patient taking antiplatelet agents, so how we're going to deal with this situation. This is a good article. It has been published in Annual of Internal Medicine, showing the continuation of low-dose aspirin therapy in peptic ulcer disease. It's a benefit in all the cause of the mortality and decreasing the mortality from the cardiovascular event with a significant B value. Despite a rebleeding, it's happened more with those who resume aspirin compared with those who did not resume, but it's not that significant. So here, if patient taking aspirin is for primary prophylaxis for cardiovascular disease, we have to stop aspirin and we resume it once it's indicated. If patient taking a low-dose aspirin for as cardiovascular, we should stop it for temporary, then resume it as soon as possible. If patient taking a dual antiplatelet therapy like aspirin and Plavix, and so in this situation, the patient has to continue the low-dose aspirin without an interruption. So the Plavix or non-aspirin antiplatelet agent should be a temporary withhold and resume as soon as possible. It's usually between 1 to 7 days. But keep in your mind, you need the cardiology to evaluate your patient. So here is a prokinetic. It's a very important pre-endoscopy to give your patient either erythromycin or metoclopramide. So here is meta-analysis examining a 5 trial, which including 316 patients were assigned to receive erythromycin, metoclopramide, placebo. So all it's favoring erythromycin is very beneficial before endoscopy. The benefit is going through improving the gastric visualization and reducing the need for endoscopic therapy. So we have to stress all our specialists and the resident to give erythromycin before endoscopy. So when to give, it's 30 to 90 minutes prior to endoscopy. The dose is 250, so you should make sure there is no macrolide allergy and patient does not have prolonged QT interval, especially in the elderly patient. So endoscopic management, very important point. You should have a therapeutic scoop with a double channel and another channel for auxiliary water, for water jet. That's very important to the intervention because if you use one channel, you will have a difficulty for sucking blood or fluid inside the stomach. So is the timing of endoscopy. This is a meta-analysis showing there is no difference between too early endoscopy or standard time of endoscopy regarding death, rebleeding, the surgery, or even long stay. So endoscopy it has to be done within 24 hours for most of patients with upper GI bleeding. Endoscopy it has to be done after hemodynamic resuscitation. So this has to be keep in your mind. You should not hurry for endoscopy without resuscitating the patient. There is no good evidence for immediate endoscopy. And a patient with ongoing GI bleeding or hemodynamically is unstable despite resuscitation, it's need an urgent endoscopy, and that will be within only 12 hours. So we will talk about the first classification for peptic ulcer bleeding. There is 6 classification. Class 1A is spurting, Class 1B is oozing, Class 2A is visible blood vessels, Class 2B is adherent clot, Class 2C is a black or red spot, and Class 3 is clean base, and you see the rebleeding is high with the first three type. Here's a picture showing ulcer with high-risk endoscopic stigmata, and this ulcer should need endoscopic therapy. So in this situation, for high-risk endoscopic therapy, you should perform endoscopic therapy in form of combination therapy using diluted epinephrine plus the second homeostatic modality, either contact thermal mechanical or sclerosant. Here, the role of epinephrine, it has to be used in 2000. Usually the dose is 1 to 2 ml. Injection, the total is 20 to 30. The role is dominant effect. It is vasoconstriction. It's a bipolar contact thermal coagulation. The setting is 15 watt. It has to be a firm pressure on the visible vessels. It can lead a cooperative coagulation. You can use the RB machine as heat probe. So other uses is the clip over the scope clip or sclerosant like sclerotherapy. This is a video for a patient presented to us last year with the bleeding from the duodenal. Anyway, here after injection, you see the area get pale. Then we did heat probe to this area, so we were able to control the bleeding. This is another type of ulcer, which is for type 1A, non-bleeding visible vessels. So in this situation, you can use a monotherapy or combination therapy. Monotherapy like clip or as heat probe, but keep in your mind if patient having like this ulcer is more than 3 millimeter, try to use heat probe, because once it's open you will not able to control it, so patient has to go for OR or intervention radiologist. So as we mentioned, if patient has non-bleeding visible vessels, is a contact thermal, mechanical, or injection of sclerosant can be used alone, or it has to be used in combination with epinephrine. So what to do with adherent clot as a first type 2B? In this situation, you have two options. Either you should do endoscopic or leave it, but they recommended to do endoscopic after performing clot removing. If you can do before it is adrenal injection, then try to remove it and manage underlying causes. Here's the salvage therapy. The topical spray is hemospray or endoclot. It's easy to use, but the problem we face a difficulty once if the tube gets blocked, you cannot use it. So before using hemospray, you should make a patency of tube before using it. Otherwise, you will not able to release the spray. The other is a fiscal clip. It's very good according to the study, but still not approved for management of upper GI bleeding. Here, that is ulcer with a low-risk stigmata as a first class 1C or class 3. In this situation, patient does not need any endoscopic therapy. He can be taking even oral PPI, and patient can be discharged. As a very important thing is a post-endoscopic care. So patient has to take IV PPI for 72 hours. Usually IV bolus is comparable to IV infusion. PPI post-endoscopic is found to reduce rebleeding and needed for surgery, but there is no role in reducing the mortality. As a very important thing is testing for H. pylori and treating it, and then you have to confirm eradication. That's very important. It has to be done for every patient who has H. pylori. The conclusion, upper endoscopy has to be done within 24 hours. Endoscopic hemostasis for high-risk stigmata of ulcer. Consider endoscopic hemostasis for adherent clot. Pay careful attention to use of antiplatelet. H. pylori has to be tested and treat. For a further reading, we suggest to go to this as a guideline as European Diagnosis and Management of Non-Peripheral Upper GI Hemorrhage. It's European Society for the Gastrointestinal Endoscopy Guideline. It has been published 2015 by Granick. And there is American College of the Gastroenterology Guideline is 2012. Here is a very nice article by Lauren. It has been published in New England Journal 2016. And the other, it's also the challenging in the management of acute peptic ulcer disease. It has been published in Lance 2013. And thank you very much.